of slows down. But if it's rising, and rising by quite a bit, that's very helpful. How high does your level need to be to see it on an ultrasound?
2,000.
About 2,000, 1,500 to 2,000. And you had a case, that's why you know. Excellent. Yep. What are some things we can do for a threatened AD, threatened abortion?
Vaginal rest.
So, pelvic rest, bed rest? Probably not at this stage. Anything else? Counseling? Very good. Very good. Progesterone. So, I looked, very little evidence to support any of that with a threatened AD. We do it to make ourselves feel better, probably, but very little evidence, just so you know.
Did you come across anything that compared PO versus intravaginal progesterone?
Yeah, it doesn't, you know, you get a low progesterone level, and you give progesterone, same amount of people go on to miscarry. So, okay, how about a complete abortion? What's the definition of a complete AD? Sort of obvious, but there's a little...
There's no cardiac activity.
There's no cardiac activity.
The cervix is now closed again?
Well, so you're done, right? So you've completed the...
First sign of essential sac.
Right, so you've seen, maybe you've examined the products of conception. You were able to, you were there, pulled it out of their uterus, or they bring it into you or something, and you examine it in the lab. Pathologist examine it, says it's products of conception. Here, falling HCG, and then diminishing symptoms. Their bleeding's decreasing, their pain's gone, and you follow their HCG all the way till it's down to 0, so you've completed their miscarriage. So what about, so incomplete, inevitable, missed, I kind of put this all in this one category. So what's the definition of an incomplete abortion? So they're still retained, os is open, and what's their bleeding doing? So they're probably going to continue. Sometimes bleeding varies, but they can continue to bleed. Sometimes they can bleed heavily. Sometimes it's episodically. But it's very hard to gauge. It's hard to predict what their bleeding's going to do. What about in an inevitable? Right. Cervix is open. Very good. What's their bleeding doing? Increasing. And if you look in your speculum exam, what are you seeing in the cervix? What's the cervix look like? Very good. That's right. So usually open, you can start to see some of the tissue coming out. So you're expecting it to happen. And what about a missed AD, a missed abortion? What's that definition? So no cardiac activity. You may see fetal pole, you may not. Someone said something over there?
Cervix is closed.
Cervix is usually closed. What about the pregnancy symptoms? Usually gone, so they don't feel pregnant anymore. Definitely, but no cardiac activity. There may be a gestational sac. Usually you see the ultrasound will show a gestational sac, but nothing in it, and their quants are going down. So management, so for these last three, the incomplete, the missed, the inevitable, there's a couple of management choices we have: surgical, medical, or expected. All are effective, but complete evacuation within 48 hours was more likely with which one, do you think? Surgical. And then the next one to have a completely, to get to a complete miscarriage is what? Medical management, and then expected. So which one had a higher risk of having an infection? They're all about equal. So really there's not one that's necessarily better than that. Which one most likely do you think will end up with more bleeding and a bigger drop in? So between medical and expectant, they'll have more, you may get more bleeding. Okay? So surgical, who do we call when we want to take care of this surgically? The obstetrician? Dr. Frost or Dr. Wood, that is right. Don't send this to the gynecologist. We can do it right here. And then that way then you guys get to do it with her, okay? So feel free to comment on this part of the talk, Dr. Frost, if you have any more. But so what patients are these candidates for? Why do we do it on certain patients?
They're acutely bleeding.
So if they're still bleeding, yeah, very good. Thanks for participating.
Thanks.
Who else?
Tissue still like incomplete.
Yeah, so a mist, probably not necessarily, because you can do medical on those, you can try medical
Not
on
a
those.
reliable patient, you know, won't come back with medical.
Yeah, so if you're worried about that's reasonable. If you're worried about them not ever coming back, or they go home and bleed and not come back, usually they'll come back in, but maybe late. Sometimes patients don't want to wait. It's hard for sometimes for women to know that they don't have a viable pregnancy and they just can't, they just don't want to deal with it. So it kind of speeds it up. And so I think emotionally, you know, it's kind of gets rid of the problem they're having and helps them move on.
Failed medical or expectant trial.
Okay. Apparently I'm covering OB. Am I? Update me shortly, but I will. What did you say, Wes? I didn't want to blow you off.
Failed trial of medical or expectant.
Failed medical, or you've gone on medical expected, it still hasn't happened. Exactly. So, who gets medical treatment?